Welcome. We are here, episode 5. When is it about the patient? Today we're going to talk about neurosurgery. I'm Chris McMahon. I have my co-host Carrie Burmeister, and our special guest today is Dr. Specka. Dr. Specka was a neurosurgeon in the area for well over 30 years. He's retired now, but he has a broad background in neurosurgery and a lot of experience, and hopefully can educate us on some things and make us smarter patients. So we're going to start this out. Dr. Specka, what would indicate to a patient they need to see a neurosurgeon?
There are a lot of things. I mean, depending on what you're talking about, anything from, severe headaches to different types of neck pain, arm and leg weakness. I mean, there's just a number of reasons that they may end up seeing a neurosurgeon. Usually they're going to see their primary care physician first, or, in the case of some kind of tragic event, they'll end up in the emergency room. But usually they see somebody before they see us.
So you're basically working from referrals.
Correct. Yeah. Everybody's that sees us has seen somebody first, and then they'll help sort it out and get them to the right person.
Now, how important is it if I'm seeing my family medicine, let's say I have a back issue, does it make it easier for you if my family practice doctor orders an MRI before I see you, or do you do that?
It makes it easier for me, but also easier for the patient if that happens. It's not always possible because sometimes the insurance companies don't let them order it. They have all kinds of requirements for getting it done. I think, we have a little more leeway in terms of ordering it. But if the patient comes out into us with an MRI after all their physical therapy, whatever they've done, then we can kind of give them a firm plan. If they don't have, then we can take a history, do a physical, and then we send them for an MRI, which then necessitates another visit. So, we love to have them come in with their MRI. If they don't, then that's fine too.
So it's just more efficient if they've already had an MRI before they see you, because it allows you to look at their films and diagnose quicker.
Right. Yeah, we can go over all the information in one sitting as opposed to having to have them come back for another visit. Yeah.
So what do you do if you have a patient who, in your professional opinion, needs surgery, but the patient doesn't want surgery?
I guess needs is an interesting word. I mean, a lot of times what I always tell my patients is you'll know when you're ready for surgery. So, very few people need surgery. A lot of times surgery is helpful in terms of speeding up the healing process. But, there are people that I see that I think, would do really well with surgery, but they're not really ready for it. And that's fine. Do physical therapy, try different modalities. If it gets better, great. If it doesn't, then they come back. And, that's when I want to do surgery, when they're begging for it.
It's probably when their quality in life is impeded by the pain, that then they're ready to have a surgery.
Yeah. I mean, there are patients that'll come in that, they want to go to surgery tomorrow. And
Yeah.
there's others that come in that'll say, you're not ever touching me with a knife, and, everything in between. So it really depends on, like you said, the quality of life. And, if you can get by without surgery, depending on what the problem is, but if you can get by without surgery, obviously that's the better way to do it.
Right. So do you ever refer to a chiropractor?
I do. I think chiropractors have a lot to offer in terms of musculoskeletal problems. I mean, there's been a number of studies that have shown that. So yeah, I find chiropractic to be pretty helpful.
Okay.
What about pain management?
About what?
Pain management. Do you ever refer to pain management?
Oh yeah. Yeah, pain management. Again, it's useful in terms of alleviating the problem, which is pain, until the underlying process heals itself up, or the patient gets to the point that they're comfortable. What I would typically tell the patient is that pain management is not going to cure your problem, but it's going to make it comfortable, that hopefully it can cure itself. So yeah, we send a lot of people to pain management.
This is just your opinion. How big of a factor is obesity?
Yeah, obesity certainly contributes to the problem in terms of, at least when we're talking about ruptured discs and that sort of thing, which is primarily what we're talking about now. Yeah, it definitely contributes to the problem, puts increased pressure on the back, and certainly people with obesity have higher incidences of disc rupture. Having said that, someday you're not going to do anything about the obesity if somebody comes in with a lot of leg pain or back pain and has failed physical therapy. Then obesity isn't going to change my treatment of the patient.
Does obesity impact the outcome of the surgery?
To some extent it does, especially if we're talking about doing a fusion. The rates of fusion are lower in people who are overweight, and the surgery is more difficult, there's no question. But again, it's something that I go over with the patient, but there's no way that patient's ever going to lose weight until they get rid of whatever their underlying back problem is, at least in a reasonable amount of time. So yeah, I mean, I go over it with them and say, yeah, the results are a little less with obesity. The surgery is a little more difficult. The complication rate's a little bit higher, but if you're miserable, then get it fixed.
Yeah, that's a good point, that they might be in a place where they can't do the physical activity if they're in that much pain. So.
Right. I mean, nobody's ever got, telling somebody to lose weight before surgery that never works. I just can't, because at least and people we're dealing with just have so much pain, they can't do physical therapy. Of course, they can diet and stuff, but still they can't be very active. So it's very difficult to lose weight before a surgery.
Yeah, diet without activity is not going to produce the weight loss they need in a reasonable amount of time.
Yeah.
How often do people require a second surgery?
Probably 8% of the time, less than 10% of the time. It depends on what you're talking about. Second surgery. So for instance, somebody that has a ruptured disc can have a recurrence of that disc. And sometimes they have it, within a couple of weeks of the surgery. That's rare. And sometimes they'll have it a couple of years down the line. So there is that. And then a second surgery can also occur if, for instance, someone has had one level operated on, one level fused. That puts a little more stress on the level above or below that, and they can come back and require surgery at that level. And that's probably 20% of those patients.
What's the most common surgery that you see or that you perform with patients?
For me, it's lumbar discectomy by far. Probably cervical fusion is next. A lumbar discectomy is the most common one.
How
and
often?
What is that?
A lumbar discectomy?
What about it?
Yep.
What is it?
Can you?
Oh, okay. Yeah, sorry. So what happens sometimes when someone ruptures a disc, the disc is a shock absorber that sits in between the bones in the back, and it's got a ligament around it, and then there's a gelatinous center. Well, sometimes that ligament is injured and a piece of the gelatinous center will push out. It's really more like crab meat, but will push out and pinch a nerve. So what the discectomy involves is making a small incision on the back, removing a little piece of the backbone, and then taking that piece of ruptured disc that's pinching the nerve. So it's a fairly minimal surgery in terms of the surgeries that we do.
Are there things that patients could do to maybe prevent, like strengthen their back to prevent having to have surgery?
The short answer is yes, but I don't think we're ever going to prevent it. Part of the problem is that our spines were made to walk on four legs, not two. So the discs get a lot of stress on them. The things that you can do that a patient can do, obviously, is be careful in terms of how they lift. When they lift, keep something in close to their body. Don't bend over and lift. Core exercises are good in terms of strengthening the back. Smoking is one. People who smoke have a higher incidence of degenerated discs. So, not smoking. We talked about obesity before, that also, keeping a normal weight also helps prevent back problems. But, like I tell my patients that have had surgery, we go over everything, give them exercises to do, physical therapy to do this, do that, be careful of this, be careful of that. But I tell them, you can do everything right. and you can come back with another ruptured disc or need another problem. Or conversely, you can do nothing right and do everything wrong and never have a problem again. So yeah, they can help themselves, but I don't think anything is ever going to prevent ruptured discs or disc problems.
How much do you think genetics impacts that?
You know, not very much, although I've had probably 3 families in my career that everybody in that family has had a ruptured disc. Every sibling, father, I don't know about everyone, but multiple of them have had ruptured discs. And, that's 3 families, 2 or 3 families out of, like you said, 30 plus years of doing this. And whether it's genetics, whether it's the way they live, but yeah, I've got, like I said, a couple families that I've operated on every brother and sister, every sibling, and, one of the parents.
You
So
answered my next question. Yeah. I wondered how common that was, where you would see people from the same family with the same condition that would need a surgery. So that was my next question.
Well, you might see people from the same problem with the same condition, because hopefully the whoever had it before has done well and they send their family members to you. That's one thing. So if you see a dad or mom or whatever, and then son has a problem, then they send them to you. And that's just kind of a patient referral. But what I was talking about before was, families where literally everyone has it. And, that's much less common.
How does the mattress, I know it sounds silly, but does the mattress, we see all these ads for better back with these mattresses. Does that really affect spinal issues?
I think it does. A firm mattress is always recommended. And patients will come to me and say, hey doc, what kind of mattress should I buy? Or, do you have any recommendations? And I don't have any specific ones. I usually tell them to find something that's comfortable, preferably firmer, because it gives you some support at night. But the bottom line is they're going to find out what's comfortable and sleep in whatever position is comfortable as well. So yeah, it helps to have a firm mattress.
So I know you guys do brain surgery, Dr. Specka. So what are the most common brain surgeries? Tumors, shunts?
Yeah, I would say tumors are probably the most common brain surgery, cranial surgery that we do. And there's a whole gamut of those, from benign to very malignant. Shunts, it depends. If you're in a large trauma center, you may do a lot of trauma as well. And then shunts, which are diversion of the cerebral spinal fluid from the brain to another part of the body, are, up there as well. But brain tumors are the most common cranial procedure that we do.
Do neurosurgeons do the TMS implant for chronic depression?
We don't. That's primarily done by a neurologist, maybe a psychiatrist. Well, I say we don't. I don't. I don't think there's anybody that I know that does that. So I think that's more along the lines of, say, when they used to, or maybe still do, electroconvulsive therapy. That's
Right.
not something that we get involved in. So it's really more the psychiatrists that do that, I think.
And then, just from your own personal experience, how much influence does the health insurance have in the course of treatment?
They control it. Absolutely control it.
Yeah.
It depends on the plan, but they all have these criteria that you have to meet in order to, in order them to approve surgery, in order for them to approve an MRI. For instance, some of them will say you have to have 6 weeks of physical therapy before we'll order an MRI. Well, I mean, the patient is absolutely miserable. There's no way they're going to get physical therapy done. And there's probably no way that physical therapy is going to help. So you've got to jump through those hoops. And oftentimes the physical therapist will say, no, we don't think we can do therapy. So we'll give that back to the insurance company, and they'll finally allow an MRI. But that whole process takes several weeks. The same is true for surgery. You've got patients who are miserable, have a huge ruptured disc. And again, the insurance company says, you need, 6 weeks of physical therapy before you're allowed to do surgery. I mean, I got to tell you, I had a ruptured disc myself. And I always said, even as I was doing this, I always said to myself, I would never have this operation until I ruptured disc. And then I wanted it tomorrow. It was miserable. I couldn't have lived with it for 6 weeks. And I think I have a pretty high pain tolerance. So, a lot of times we're fighting the insurance companies in order to do really what's right for the patient. And, of course, they have their paid peers that we have to talk with and get approval from to do various types of things.
That's my biggest complaint, is because when you do a peer-to-peer, and this, I'm not disparaging any profession, but for all you know, you're talking to a podiatrist.
Oh, I've talked to pathologists. I will always ask them, I'm doing a peer-to-peer. I say, well, what's your specialty? Pathology. I said, well, you're not a peer. I need to talk to an orthopedic surgeon or neurosurgeon. And it's not disparaging pathology, or, if they have family practitioners do it. And all they're really doing, honestly, is they have a little sheet of paper and they have checklists. Has the patient had physical therapy? Have they done this? Have they done that? And unless all those boxes are checked, the peer that you're speaking with is going to deny it. There's no peer-to-peer discussion. It's just a matter of checking these boxes. They could hire a 6th grader to read those boxes and check off the check boxes.
Exactly. That is.
So, Chris, I think we should explain what a peer-to-peer is.
That's a good point.
So go ahead.
So a peer-to-peer is when a patient has. I'm sorry.
Nope, you go right ahead.
Okay. So a peer-to-peer means a physician-to-physician contact for a certain patient with a specific problem. So what happens generally is we'll order an MRI or request surgery. That request goes to the insurance company, and somebody there looks at it and denies it. And then we have to go back and say, okay, we want to do a peer-to-peer. So what happens then is a physician gets on the phone, who is working for the insurance company, gets on the phone, and then I speak with him, explain what's going on and why I think the patient needs to have surgery. So that's what a peer-to-peer is. When you're talking to another peer, the insurance company's definition of a peer is a physician. My definition of a peer is, a spinal surgeon, whether it's orthopedic or neurosurgeon.
Yeah, and that's, I think, one of the issues. I think the insurance companies, as we know, they employ the physician. So they're working for the insurance company, and the insurance company does not employ every specialty. They may have a family medicine physician who they employ to do all their peer-to-peers. And so it doesn't matter what your specialty is. I think they assume that because they know medical jargon, that then they can filter if it's warranted or not. But yeah, you're not always talking to one of your peers in your profession.
And they're looking for specific verbiage as well. For instance, I had a patient once who had severe radicular arm pain, which means they have a pinched nerve in the neck causing pain that goes into the arm. And the radiologist read the MRI as showing ruptured disc at C5-6 with a fragment compressing the nerve root. And in fact, there was a fairly large fragment of disc compressing the nerve root, but because the radiologist, who's never examined this patient, has never seen this patient, didn't say large fragment, the insurance company denied it. So even if I get on the phone and talk to the peer and say, well, look, I'm looking at the MRI here. And again, the peer has not looked at the MRI. He or she has not looked at the patient, but I've seen the patient, seen the MRI. I say, look, there's really a big fragment of disc compressing the nerve. The peer will say, well, unless the radiologist says large, then, I can't approve it. So now I have to go back and talk to the radiologist and say, can you put large in your report? So he puts large in his report, and then we send it in and they approve it. And even though I tell the peer, I said, look, this is what's going to happen. You're just denying care. I'm going to send this, I'm going to call the radiologist up. There is a large fragment, but because he didn't use the term, we've got to get him to put that in the report, which, again, takes several days. So again, the care is delayed. But so my point is that you would think a peer-to-peer, you would be able to have a discussion and come up with a plan. But again, they go back to the checking all the boxes, unless it says large ruptured disc, it gets denied, no matter what the physician who's seen the patient, seen the films, and it says.
That's one of my pet peeves is they deny and delay something that ultimately they're going to end up approving, but they make the physicians jump through hoops. Consequently, they also create more work for themselves on their end. And at the end of the day, once you have all the verbiage right and whatever, so they can check all the boxes, they're going to ultimately end up approving it, but they just delayed care to the patient, who is actually the person who pays them for that care, for that insurance. And for weeks, because of stupid things that aren't in a report. That's one of my pet peeves with insurance.
Well, and I've talked to, they keep records of who they talk with, and and I've talked with them. I said, look, this is going to get approved. All of my peer-to-peers get approved eventually. It's going to get approved. Why not just approve it now? And they'll say, well, yeah, I'm looking at the records, and maybe not all of them get approved, but 99% of yours get approved. And I said, well, then just approve it. He says, I can't, because it doesn't have the correct verbiage. And, you'd think, well, they're going to pay for it anyway, so why not save themselves time and money and just do it up front? But think about how much money they're making while those funds are invested. I mean, you're talking probably billions of dollars that are invested in something that, as long as they're not paying it out, they're making money. So, the longer they delay it, the more they make off their investments.
Oh,
so
exactly.
They figure it all out. They know where the the break even point is. And I think also there are physicians who don't want to bother with peer-to-peer, and they're just hoping, we'll give up, or the patient, the physician gives up, won't do it, or the patient gives up and goes away. There's that too.
And sometimes that works, I think, for some things.
No. There's
but
no question.
If a person's in a lot of pain, clearly they're not going to go away. They're going to obviously get done what they need to get done and keep pressuring the doctor and coming back for visits until everything's worked out. But no, those insurance companies want to sit on their money. You're 100% right. And delay, deny is one of their tactics. And unfortunately, with the volume of things that are billed and then denied and come back, people have no idea how much time and energy at the physician office level is spent just trying to get the ducks in a row so the insurance company will pay for something.
Yeah, no, absolutely. And, I've had an instance that I've known for sure, and I suspect it happens more. The insurance company blames the physician's office. Well, your doctor didn't send this, your doctor didn't send that. And, you look, and you've got, obviously have documentation of when it was faxed in. And I've gotten on the phone with the insurance company and the patient in a three-way call saying, no, it isn't physician. Here's when we sent this. Here's, this is what we did. Insurance company, it is your problem. Don't blame it on us. So the patient knows. But yeah, they're telling the patient that your doctor hasn't done something correctly, and that's why it's being denied.
Yeah, because they're not going to own it. When the patient calls them complaining, they will never own it. I know just from my past experience, their favorite thing to say is it wasn't coded correctly.
Yeah.
And when the patient would call me and complain, I'd have to explain to them, look, they didn't want to tell you this isn't a benefit. They're never going to pay this. Okay. I said, we coded it right. We do this every day. It's coded correctly. We're not going to change it. We're not going to falsify it. It's coded correctly. They're not going to pay it. It's not a benefit. Unfortunately, this is an out-of-pocket expense for you. And you just have to tell the patient that. And that's not what they want to hear. But the insurance company will never sit there and tell them it's not one of your benefits.
Yeah.
So I hate it.
And I think we need to, this is all about the patient. So once again, we're delaying care for a patient in pain or, with some sort of ailment or issue. And again, everyone's trying to do the right thing, and they're the ones that are being delayed.
Honestly, it's not just about pain either. It's about patients who have malignancies, they have cancer. You're trying to get studies done, you're trying to get treatments approved, and it's no, no, no. Deny, deny, deny. And, it's just horrible.
It is. And I think, and Dr. Specker, you probably know better than I do because you were practicing in medicine back then, but 25, 30 years ago, you didn't go through all this.
Oh, no.
To get a surgery scheduled. It didn't require that. And I just think as insurance companies and things have learned to hang on to their money, back in the day, it just wasn't that hard.
No. And, the insurance companies themselves are making billions. The CEOs of the insurance companies are making, $20 million a year. And yet people who are paying for services are not getting them. It's horrible.
I know. And I don't really like to beat up on the insurance companies. They're a necessary evil, but they are the ones that prohibit patients from getting the care they need when they need it. I mean, I forget, just recently someone called out Anthem for a patient with cancer. It was on the news and they were not going to pay. Well, they backed down and relented and they agreed to cover the care. But you shouldn't have to go to those extremes to get something paid.
I mean, especially when you're, going through the emotional, not only physical, but the emotional turmoil of having cancer. You shouldn't have to worry about getting treatment and fighting to get treatment. Just get it done. But they don't care. They really don't.
Well, when you see a patient, and let's say the patient knows something's wrong, we'll just use a brain tumor because it's kind of easy. And you see this, your MRI, and you tell the patient you have a brain tumor, it's operable, and explain the steps you have to go through. I think once you tell that patient they have a brain tumor, I don't think they hear much after that.
You're right. You're absolutely right. Nope. You're absolutely right.
Because they have to process that, so they're going to go home. And if there's a family member there with them who is smart enough to ask the right questions on their behalf, then in that case they can. But I just think at that point, a patient, they just stop hearing everything and then they go home and they're like, oh my God,
Well, I mean, there's even a worse issue is kind of the my chart stuff. Every result gets put in the chart when it's done. And I think there's ways to prevent that, but it oftentimes doesn't happen. And I've had patients who on Friday afternoon will look at my chart for the results of their MRI and it says brain tumor. Yeah. And they've no one to turn to for the whole weekend. Now, it might be a benign brain tumor that's easily dealt with, or maybe not. Maybe it says a glioblastoma and they go and look up glioblastoma and they're sitting there by themselves, with their family, but nobody to guide them. And so, the my chart stuff is an issue too, putting everything out before, the doctor sees it.
Well, the timing of the release. Yeah, I know you do. You see those things because I see them and they put a qualifier at the top of your chart that says this has not been reviewed by your care provider. So they're letting you know that, the physician hasn't seen it yet, but it's still out there and you can see it and read it. And
yeah, I mean, I can't even imagine being in that. I mean, I've had several with the brain tumors that, see them before anybody can talk to them. And then their primary care docs call me up and can you get them in today to talk to them? Yes, we'll get them in. We'll talk to them. But it's the ones I've had a couple that seriously Friday afternoon, they read that they've got a malignant brain tumor and, they have nowhere to turn.
Yeah, but that's all a government mandate.
Oh, I get it.
That-
Yeah, no, I understand. Yeah.
That's not health systems wanting
No,
to do
no,
that to patients.
no, I
That's
know.
the government. And unfortunately, the health systems have to comply because they do get funds from the government, don't they, Carrie?
Yes, they do.
Yeah. So it's one of those, it's a catch-22.
Yeah.
But another thing I wanted to ask you about is expectations of surgery. I think a lot of people, like, let's say you have a fusion on your back and they think, well, once the surgery's done, I'm going to be good as new. When the reality is you're not really good as new because someone has cut into you. They had to cut in there, they moved things around, they did whatever, and they stitched you back together. It will never be good as new.
No, and I tell patients before surgery, I said, we're going to fix this problem. You're going to feel better, but I am not going to get rid of all your pain. Now, so I mean, part of that is managing expectations. Sometimes with a lumbar disc, you can get rid of all of their pain, but I always say, look, you're going to have issues. You've had a ruptured disc, so for whatever reason, you have a chance of having another one. It's not because you've had surgery; it's just because of your lifestyle or the way you're put together. But yeah, I tell everyone I am not getting rid of all of your pain. Now, sometimes they don't hear that, and they'll come back after their surgery and, doc, my little toe's still numb. What are we going to do about it? And it's like, look, you couldn't walk before surgery, so we're not going to do anything about it. It's all relative. But you try and manage that expectation before surgery.
Yeah, that's a good point. But I know that I think that a lot of people just have to learn to live with the pain because
Yeah.
there's not, there's only so much you can do.
Yep. Yeah.
What's
I mean,
the timing from the time when you first see someone that needs surgery to finally getting them their surgery? Is it 2 weeks or depending?
it totally depends on what's going on with the patient, and it depends on the insurance company. I mean, honestly, I've had patients who are miserable that I see in the office, and if they'll let me, if I can get it approved, I'll do the surgery the next day. Just because having been there, I know what it feels like. Or there's a thing called trigeminal neuralgia, which is just horrible, horrible facial pain. I mean, that pain is so bad that patients will kill themselves if you can't get rid of the pain. And I've always considered that an emergency. So, I've had patients that I've done surgery on and then it recurs. I tell them, call the office, and just talk to me and we'll get it set up for the next day. But I mean, that's kind of a rare case. But so in terms of a lumbar disc or the typical disc surgery, it really depends on the insurance company, depends on how much pain the patient's having, and it depends on what the patient wants to do. Again, there's people that I know when I first see them, or I think strongly you're going to end up with surgery, that have no interest in doing it. And that's fine. I'll help them do whatever else they need to do. And, whenever they come back to me, we'll get it taken care of. So, and I mean, a lot of it is scheduling issues, insurance company and the patient. So it could be anywhere from the surgery gets done the next day to, 3 months later.
3 months is a long time to live with something that's
Yeah, no, but if you're fighting the insurance company for everything that you want to do, and yeah, it can take that long.
Well, I'm out of questions. Carrie, you have anything else?
No, I think you were starting to ask what has changed in your field in the past probably 20 years. What things have changed for you? We talked about the insurance and the requirements insurance. What other things have changed in the field in the past 20 years?
Yeah, it's a good point. Probably the technology is really what's changed. When I first started training and doing surgeries, I mean, we did very few, if any, instrumented fusions. That's when you put screws in the patient's back and then fuse it. That has then that kind of evolved to be doing more instrumented fusions as we found out that it worked better. So we did more open fusions, and then there became the minimally invasive approach where a lot of these things can be done through a tube. And so it's a much less invasive procedure. And more recently, and not, in the last probably 5 to 10 years, robots are being used to put the pedicle screws in. And again, that's a much less invasive procedure. There's also more procedures, I think, that the pain management doctors are doing that we used to do, different types of fusions they may try and do. But yeah, the biggest change has been the trend toward minimally invasive surgery, which, can get the patient out of the hospital sooner, can cause less pain, can cause less blood loss. So that's probably the biggest change.
And those are all good advancements for the patient.
Yeah, they are.
That's about all I had, Chris.
Have the patients changed?
Yeah, patients have changed. They, right or wrong, I mean, they expect more. It used to be, 30 years ago, the doctor was sacrosanct. And now the patients have been taught to ask questions. What's going on? Why are you doing this? What are my options? So they can be more demanding, which is not a bad thing. So yeah, I mean, the patients definitely have become more knowledgeable. I think the internet has contributed to that. And have learned that they have a voice in the process. It's not just go in and this is what the doctor says and this is what you're going to do.
Yeah, 30 years ago, they just did whatever the doctor said and they did not question it at all.
Yeah. Yeah.
And I think that patients have kind of evolved with that. There's just more out there, more education out there, more things that they can read. We didn't have Google back in the day, so I couldn't go Google it and see what Google told me should happen. So yeah, it's just with society, with the changes in society and people just having more access to different knowledge, I think that has played a part. So
yeah, absolutely.
But not a bad thing,
actually. No, not at all. I mean, it's good to question. I mean, some physicians take umbrage at it. I had a friend of mine went to see a oral maxillofacial surgeon for some issues, and she had a number of questions, and he finally just said, "You see all those degrees on the board? You listen to me. You just do what I do." Well, he was gone, never went back to see that guy. That's old fashioned, You just can't do it anymore.
I hear you. Any other questions, Carrie?
Nope, I think he's answered everything.
I know. I really appreciate your time, Dr. Speck. This has been really informative. I appreciate it. And it's been good talking to you, and enjoy the rest of your day.
Will do. Thanks. Good to see you guys.
Dr. Speck.
You're welcome.
Thank you.
Yep. Bye-bye.